This is Dr. Robert Applegate, Wake Forest School of Medicine. Welcome to Planet COVID and SIF 2020 Virtual. I am pleased to present Coronary Revascularization Pre-TAVR. Why, who, and when. I have no disclosures for this presentation. Here's a brief outline of this presentation. I will start by talking about why PCI prior to TAVR. Shown on this slide is the prevalence of coronary artery disease in multiple clinical trials evaluating TAVR. The incidence was as high as 80% in the initial extreme risk studies and as low as 20% in the more recent low-risk trials. On the right-hand side of the slide, we see the incidence of revascularization from recent TAVR clinical trials. The incidence of revascularization was substantially less than the prevalence of significant coronary artery disease, indicating that the mere presence of significant CAD was not the sole basis for performing revascularization in these trial patients. The initial revascularization strategy for patients with CAD undergoing TAVR was based on experiences with surgical aortic valve replacement and concomitant bypass grafting. Shown in this slide is the Cleveland Clinic experience in patients undergoing aortic valve replacement alone versus those who underwent combined CABG and aortic valve replacement. These authors observed that in matched patients who had concomitant CABG and AVR, outcomes were not significantly different than in those who underwent aortic valve replacement alone. However, in patients who had experienced evidence of myocardial damage or who had extensive comorbidities, the outcomes were substantially worse when CABG and SAVR were performed together. They concluded that patients with severe aortic stenosis and CAD risk factors should undergo early diagnostics and aortic valve replacement plus CABG before ischemic myocardial damage occurs. On the basis of these kinds of study, the AHA-ACC 2014 guideline for management of patients with valvular heart disease developed an algorithm for revascularization. Patients who have symptoms of angina, risk factors for coronary disease, prior CAD, LV dysfunction, or objective evidence of ischemia should undergo coronary revascularization if greater than 70% diameter stenosis is found at a major coronary artery or greater than 50% diameter stenosis of the left main coronary artery. These recommendations form the basis guiding revascularization in patients being evaluated for TAVR in its early experience. As we moved into the TAVR area, reports emerged assessing the influence of CAD and revascularization in patients undergoing TAVR. Shown here is a single center experience from Israel looking at the residual syntax score on outcomes in patients undergoing TAVR. These authors concluded that in patients undergoing TAVR, it is the severity of coronary artery disease as assessed by the residual syntax score that is associated with worse prognosis and not the mere presence of CAD. By contrast, the Thorax Center, evaluating 263 consecutive patients undergoing TAVR from 2005 to 2012, found that the completeness of revascularization had no effect on clinical outcomes after TAVR. Based on these and other contemporary registry data, it is clear that a consensus on who should undergo revascularization in patients with significant CAD undergoing TAVR is currently lacking. Fortunately, there are multiple randomized clinical trials underway specifically examining the issue of CAD in patients undergoing TAVR. Several of these will evaluate the utility of both coronary CT and physiologic assessment, including FFR and IFR, in identifying patients who would best benefit from PCI. We eagerly await these results. Next, we will examine who should undergo PCI prior to TAVR. This slide outlines the strategy for who receives revascularization prior to TAVR at Wake Forest in 2020. We initially identified the TAVR risk status as well as the extent of coronary disease. In those patients who have a high syntax score greater than 32 and are low to intermediate TAVR risk, we favor TAVR plus CABG over PCI plus TAVR. Whether a large amount of myocardium is subtended by CAD and LV function are next evaluated. Finally, we evaluate several other factors shown here to determine if PCI should be performed. We will look at two cases which illustrate the individualization that occurs during the decision to perform PCI prior to TAVR. Case number one is an 85-year-old female with symptomatic severe aortic stenosis and with multiple comorbidities, STS score of 6.3, and deemed intermediate to high risk for TAVR. Shown here are the coronary angiograms of this patient. There was extensive distal left main and LAD disease, a subtotally occluded circumflex intent, and non-obstructive right coronary artery. The heart team reviewed the coronary angiograms and the patient's case and recommended PCI of the left main in LAD to minimize ischemic-mediated LV compromise during TAVR. The patient underwent lesion preparation with orbital atherectomy, followed by balloon angioplasty, and finally drug-eluting stent placement of the left main into the LAD coronary artery. Shown in the middle panel is IVUS imaging depicting a final MLA of the left main stent of over 8 millimeters squared. She underwent staged TAVR with a 23 millimeter S3 via a right femoral artery approach. The patient was discharged after 2 days and doing well at 6-month follow-up. The next case depicts a woman in whom a decision of no revascularization was made by the heart team despite similarities in coronary artery shown with the previous patient. Case number 2 is an 81-year-old female with severe symptomatic AS, extensive history of coronary disease, as well as peripheral vascular disease, which would become relevant during her evaluation. She had an STS score of 9.8 and was considered to be high risk for TAVR. This patient's vascular disease was extensive, with right brachiocephalic subtotal occlusion, right femoral artery occlusion, and tortuous left subclavian, although the catheterization was ultimately performed with extreme difficulty via the left radial artery. Shown here are her coronary angiograms revealing significant diffuse calcific disease of the distal left main and all the major epicardial vessels. The heart team evaluation of this patient recommended no revascularization given the absence of angina, complex coronary revascularization strategy needed, and extensive vascular issues noted above. The patient underwent uneventful TAVR with a 26 millimeter core valve via a left carotid cut down. She is now 2 years out from her TAVR without a coronary event. I believe these two cases highlight the complexities in individual cases as well as decision-making in patients with severe CAD and aortic stenosis. Finally, we will discuss when to perform PCI in a TAVR patient. Shown here is a comprehensive review evaluating the timing of PCI in patients undergoing TAVR from several large registries. These observations indicate that concomitant PCI plus TAVR is associated with the highest 30-day mortality. Based on these observations, the authors recommended that PCI should be staged prior to TAVR and serves as the current recommendations for timing of PCI. I hope this review has been educational and informative. Thank you.